Hi, everyone. Thank you so much for joining us today for our quarterly webinar, Key Regulatory Topics for Women's Health Businesses. As many of you know who have joined us in the past, we do these on a quarterly basis. My name is Kayla Marty, and I am generally part of these different quarterly webinars, and then we have various guests that join us each quarter. So today, one of our guests is Tim Fry, who's one of our partners at McGuireWoods, focusing on key regulatory topics and often jumps in for different of our women's health business questions. And so for people on the phone that have not joined us in the past, Tim and I are with McGuireWoods, a large international law firm with a strong healthcare focus. And I lead one of our women's health and fertility working groups that puts out a substantial amount of thought leadership on these different topics that are relevant to our women's health and fertility clients and contacts. So we have historically focused these webinars on heavily regulatory and transactional issues. As many of you know, we counsel independent practices, MFMs, OB practices, fertility practices, as well as large private equity-backed portfolio companies, some PE funds, and then also increasingly hospitals related to their various laborist programs. If you're interested in joining us for future webinars, please be on the lookout for our next series, which will be happening on May 17th, and we'll focus on fertility issues with a panel of distinguished guests that are experienced in the fertility industry with independent practices, portfolio companies, and an investment banker. If you are eligible for CLE, CLE will be offered for the presentation today. We will be giving instructions throughout the presentation, so just be on the lookout. And you can access the CLE paperwork under the Resources tab on your platform, and we'll give more information throughout the presentation about how to access the codes and obtain credit. So with that, we'll just move on to our agenda. So the agenda of key topics that we decided to discuss are not necessarily interconnected, but they are all things that we have been getting significant amounts of questions about from our clients and contacts over the past 6 to 8 months. So just to review, we're going to be talking about implementing alternative payment models, expanding ancillary service offerings, executing multi-state growth, and navigating complicated outside physician relationships such as lab, imaging, and other ventures. And Tim is going to jump in and talk about our expanding ancillary service offerings and executing multi-state growth when we get to that portion of the presentation. And I'll be focusing on implementing alternative payment models and navigating outside physician relationships. So with that, we'll just jump right in. If at any time anyone during the presentation has a question, please direct your question to the Q&A box on your platform. Tim and I will do our best to answer those during the presentation or at the end. If for some reason we're unable to get to your question or it's too specific that it wouldn't impact everyone, we'll reach out to you separately. And at any time, please always feel free to reach out to Tim and I with any questions that you have, whether you're a current client or not. Our contact information is on the first slide, and the slides will be redistributed after the presentation. So with that, let's talk a little bit about implementing alternative payment methods and models. We have talked with many of our clients and contacts over the last several years about ways that they can transition to a solely fee-for-service model to more innovative and risk-bearing relationships. And there's a number of different models that we answer questions about frequently. By no means are these the only models. They're just the ones that we see very commonly. So we thought we would go through those first and then talk a little bit about strategies. If you're looking to move your organization from a fee-for-service model to more alternative payment models, obviously recognizing that in the current climate, there will be no full or alternative payment structures, but it is a pathway that we're seeing many payers and practices move toward. And this will also be relevant for various advisors, PE funds, other capital providers that are looking to understand these different models. So with that, we'll start with the first model. In many ways, people view this model as what I would call a rate-impacted model, or a baby step from fee-for-service onto a more alternative payment method. And generally speaking, what we're seeing in the OB, in the MFM space, is payers are starting to incentivize providers to provide more efficient care based on site of service. So you may be experiencing this in your own practice, or you may be seeing it in transactions that you're looking at, but you can often see increased or decreased global payments for a pregnancy based on decisions made to control the cost of care. A great example is site of service with respect to health systems. Many commercial payers are starting to implement or incentivize providers to use the lowest potential cost setting of care by paying them more for making that choice. So for example, if the cost of care is, in a very simplified example, $2,000 to go to hospital A, but the cost of care is $5,000 to go to hospital B, payers are working, when clinically appropriate, to drive cases into hospital A. And so many of you are probably seeing this in your all's practices, or in practice that you are diligencing, and that's something to just be on the lookout, because it is a baby step toward alternative payment models. This can often directly impact the compensation of your individual providers. If you have a large group of providers, particularly a group that is across different states, you will see different providers referring to different hospitals and utilizing different sites of service that may dictate cost of care. And so you really have to consider that in your compensation models and in your discussions with payers on whether or not you're comfortable with this rate-impacted structure. And sometimes it's forced upon you. It's not necessarily a choice by the payer, but it's something to be very aware of so you can educate your providers and be able, when clinically appropriate, to take advantage of those savings. And like I talked about earlier, this is a structure designed by payers to decrease the cost of care when clinically appropriate. And of course, we're still going to have cases that it is never clinically appropriate to move into a certain setting or to drive to a certain facility due to travel time. But when possible, payers are starting to encourage that decision-making, which is what you're seeing in this rate-impacted model. The second model that we talk about a lot is what I call practice-level capitation. So it's your individual practice is taking on a certain number of lives for a payer, and you're receiving a prepaid premium to deliver certain care for those patients. Typically speaking, we are seeing this most commonly among pregnancies because it's the most costly care often provided in women's health businesses rather than your typical appointments or your typical GYN procedures. So payers are more focused on this issue for pregnancies than anywhere else, and we are seeing it among different types of payers treating it differently across different geographies in the United States. So a lot of times our clients are coming to us and they are asking us, how can we distribute these revenues? How can you help us understand compensation methodologies that can align practices by the individual physicians? So we've often helped clients with that structure. You'll need to think very critically if you're moving into any kind of practice level capitation on how you're going to distribute revenue to the physicians such that they do not have different incentives than they had prior to implementing this alternative payment model, and to ensure that the care, again, is being provided in a clinically appropriate way. But it is a way that the payers are allocating risk to the providers and encouraging them to manage the cost of healthcare. So as seems obvious, it is going to reward low cost, clinically appropriate, efficient healthcare, which generally speaking, different Medicaid providers and different payers are very interested in, and providers are starting to also become interested in because it can have upside. One thing that is a very common question we get is how do we protect against the downside risk associated with this practice level capitation? And the bottom line has often been there are some things that you can control and there are some things that you cannot control. So the things that you cannot control, obviously, are catastrophic diagnoses or specific clinical issues with certain patients. That's going to be largely outside of the practice's control. But what they can prepare for and track efficiently is data with respect to those type of diagnoses over time and the cost of those type of diagnoses over time. And when a practice goes to a particular payer to negotiate these practice level rates, it can do so with that data in hand. And so this is going to be a global theme that we see across all alternative payment models. It is critically important in order for them to be successful for a particular practice or a private equity fund who's interested or managing a practice or someone who's diligencing a practice to understand the data that's being collected and the behavior of the particular practice to ensure it doesn't become a cost center for the practice that was not previously there. So this is just one example of this type of alternative payment model. The next alternative payment model we just colloquially call bundling payments. And this is the most sophisticated payment model that we see people commonly looking at. It also has the most upside and downside. And what we have seen different of our contacts and clients doing across the market is they have been negotiating with payers to bring in the cost of care for multiple types of services, particularly provided to a pregnant woman. So this would include things like the OBs, the MFMs, the anesthesiologists, and sometimes even in some cases, the health system. And essentially what is occurring is there is either the practice is acting as a convening entity for all of these different stakeholders in a women's continuum of care, or they're actually forming a separate legal entity that acts as the convening entity. And the payer is paying to that convening entity a premium for the full cost of service of care for the woman and her pregnancy. Then the convening entity has the responsibility to contract and manage that care for each of the different stakeholders that I mentioned. So the OBGYNs, the MFMs, the anesthesiologists, and in some cases, facilities. And so by having contracts with the convening entity, the payer is able to manage the total spend for a pregnancy involving one child and then ultimately multiple lives. And that is giving the payers certainty about their spend, which they find attractive. It also has the possibility of rewarding providers for providing clinically appropriate, efficient care rather than just number of visits in a fee-for-service type model. And so this is something, as we've talked to different contacts at different payers, we've seen them very interested in this model and interested in seeing providers move into this arena. That being said, it can be very difficult to do. And we work with many of our clients to understand the different risks associated with it. And there's really two main types of risk. One is the business risk. So if, for example, the care cannot be provided in a clinically appropriate way in order to be done within the payment premium that's being given by the insurance provider, then you'll have a situation where you have a loss at this convening entity, which obviously is difficult from a business perspective. The other challenge that you can have is with fraud and abuse statutes and insurance laws, depending on who's acting as this convening entity, what the contracting parties are with the convening entity, and then who the convening entity's owners are. So it is critically important, because there is a financial relationship between this potential convening entity and various different providers that are often also referral sources to this continuum of care. It's important to look at each of the fraud and abuse statutes from a federal law, which include the federal anti-kickback statute and the federal Stark law, which we'll talk about a little bit later, as well as all state insurance laws that can impact how these convening entities are operating. And so that's just a very brief primer on one of the questions that we're seeing from our clients very frequently, and there are some pitfalls with it to be aware of as you start to look at those potential issues. The next thing that we often have asked are, what is the strategy for implementing any of these models? How do we start this process if we're not there yet? Or how do we take the next step in this process? And so we've come up with some tips here that you'll see on the slide that talks about the different steps that can be taken. So number one, and always the first step, is investigating which model is available in your market with your payers. Because as many people on the phone who've already implemented some of these models have seen, is some payers do not offer all or any of these models in particular markets across the country. And in some situations, it's actually been large practices that have taken these models to the payers to try to get them on board with implementing them in their geography. So if a model is not available with one of your payers today, it doesn't mean it's impossible to implement with a payer, but it's going to be a lot more work to get the payer to understand it and get the payer on board with it than if the payer is already doing it in your market. The next thing is engaging staff resources to be able to manage the model. Since these models are so different than a typical fee-for-service structure that many have been accustomed to, it's really important that you have the resources in your practice, or if it's a practice you're diligencing or you're looking at, they have these resources in order to bring these alternative payment models online. Because as we discussed, they have a substantial amount of risk with them if they are not done properly, both from a business perspective and from a regulatory perspective. So making sure that you have the right people to help you, either in the way of consultants, attorneys, or internal staff, is very important. The next thing is model the desired economic output. Every alternative payment model will not work for every referral pattern and every practice across the country, depending on what your patient type is, what your physician's referral patterns are, how many different health systems and other providers you engage with. That's really important. You have to model out the economic impact to really do this in a thoughtful way. And combined with that is understanding your referral patterns of your business. Because going back to the first model that we talked about related to rate impact, if you are always have providers that prefer to refer to the highest cost hospital setting in your market, it may be difficult to implement that rate impact without significant buy-in from your physician partners and understanding their referral patterns. I also would recommend evaluating potential economic risk. So there are always downsides of all of these economic payment models because you are receiving often a set payment for the total continuum of care. So it's really important to model not only the potential upside, but also the potential downside, and come up with a list of ways that that potential downside can occur, and look back at your practice's previous data to determine how likely those things are to actually occur. The next thing is tracking and data pathways. So it's very important with payers to be able to negotiate rates based on data-driven approaches. And so in order to really effectively implement these pathways, then I would recommend that you make sure that you have the appropriate data to track outcomes. And then when your payer contracts are up for renewal with respect to different models, you also will have the outcome to show what has been saved to the payer and what clinical efficiency has been gained. And then the last thing is, make sure you're analyzing the regulatory risk or reporting requirements with every alternative payment model. Just because an alternative payment model may be permissible in one state does not necessarily mean that it will be permissible in another state. So as you grow, and what Tim will talk about related to multi-state growth, one size will not fit all with these different alternative payment models. So just make sure you're consulting your advisors on whether it will work for your particular model. So I'm going to pause here and talk a moment about the CLE portion here. If you go into the other resources box, you'll see an affirmation form that can be found and submitted per the instructions. If you don't mind to just put in this code that's listed on the screen, which is MW Women's Health 22 and submit it to the email address on the paper, then we can ensure that you receive CLE credit. We'll now be moving into our next discussion, expanding ancillary service offerings and multi-state growth. Tim, if I can turn this one over to you to jump in on this question.
Thank you, Kayla, and it's great to join you all in our entire team at McGuireWoods. Thanks you for your time today. Hopefully, good lunches while you listen to us, and we don't give too much indigestion hearing from lawyers on regulatory issues. But these things get us excited, and I think you heard it from Kayla. We've seen so much in the space, and a lot of investors interested in women's health and related things like pregnancy, delivery, fertility treatment and whatnot. It's very, an area of a lot of innovation, both in business models and in care, and certainly alternative payment models. Quite honestly, for Medicaid providers, they've been doing some of these bundles for years. The pregnancy is a bundle and not a traditional fee-for-service payment, and includes everything from the delivery care to the delivery to some post-op visits. So this is not new necessarily for women's health, but it is an area that, as Kayla noted, especially for groups that have good clinical data, there's some great opportunities to use that and push towards the future and push towards new bundles to save costs. As I switch to fee-for-service, however, which is where Kayla asked me to jump on, is, hey, what is ancillary services looking like? What is, as these platforms we're working with grow? Just want to note that, Kayla and I would both love to continue this conversation with you after today and get some feedback and participate. And so one way to do that would be through LinkedIn, and I'd welcome you joining, my network on LinkedIn, reaching out, and I know Kayla would be the same and would love to have a short conversation with you on some of these topics. But ancillary services are ones that you're all familiar with, and we're starting here on this first slide with imaging services, mammography services, services that are paid for in the fee-for-service context based on taking the image, reading the image, giving a report, and then follow-up treatment care. And these services are important because they implicate some of the laws that are on this slide. And you have two lawyers presenting to you today. You have to have some laws referenced. And in my context as a former CMS employee, I have to talk about the physician self-referral law, the so-called Stark law, the strict liability federal statute that will come into play if your group is doing services, imaging services that are paid for by Medicare or Medicaid, we'll come back to that, on an image-by-image basis. Some ultrasound services aren't separately billable in women's health space. Oftentimes will be part of a bundle or part of the care continuum. And so those services, imaging, do not necessarily implicate the self-referral law, but certainly many other imaging services you may look to offer would be. If we're talking about Medicare and Medicaid, we also have to talk about the federal anti-kickback statute, which has the referral prohibitions if there is an intent to induce referrals, state equivalents, and other billing issues that many of you on the phone have dealt with for many years, and so more just flagging these are issues and setting up the conversation to come. In the women's health space, ancillaries also often include pathology and lab services, and these can take a variety of different types of labs, from your very traditional pregnancy testing to Pap testing to, biopsies and other types of pathology. It also now, certainly over the last 2 decades, includes a lot of genetic testing for pregnancies and testing of the children for deformities and whatnot that can come out in very high-end and very expensive tests. And so when we're talking about labs, in some specialties like dermatology, we're talking about a single pathology lab, very standard review of cancer. In the women's health space for clients, we often see much smaller regional-based labs, but then also with some of the more expensive, the more high-end equipment, the cutting-edge kind of genetic testing is secondary or more national labs. And so when that happens, it brings in some other laws, including those we had on the prior slide. It brings into play things like CLE regulation, state regulation in states like New York and Washington that really can get into each piece of equipment needs very different regulations in place. We also have to worry about the Eliminating Kickbacks and Recovery Act that, if you ask me, Congress messed up. They were trying to stop opioid lab schemes, but they've applied it to all labs, and DOJ is taking those cases. And so kickbacks, even if you avoid Medicare and Medicaid and you pay kickbacks, the DOJ will go after you if you have a clinical laboratory. And so this Eliminating Kickbacks and Recovery Act, ECRA, was a part of the opioid legislation. But every time the government gets a new tool, they use it to the maximum authority, and that's what they've been doing. So when you're thinking about ancillaries, you have to be careful, but everybody does them because of what they can do for an organization. On a prior slide, I mentioned these ancillary services will apply to both Medicare and Medicaid. This, believe it or not, is the lawyer's fun slide. Hey, the Stark Law, that's a Medicare law, right? It's in the Medicare statute. CMS has said with its regulations that it really only applies to the Medicare program. Their regulations only apply to the Medicare program. Congress actually every term has someone who introduces a Medicaid Stark Law bill, or at least they have the last few sessions. But yet, I always would tell a client Medicaid Stark Law is applicable, and the reason it shows up on this slide is there is a prohibition on paying states that manage their Medicaid programs if that payment would go to a violative referral, meaning the penalty under the statute is not supposed to be to the providers, not to those of you on the phone, it's supposed to be to the state government. Well, you can imagine how often the states have been penalized under that law and that rule. And you can imagine how difficult it was at CMS for the agency to put regulations out. They never have. They've never finalized regulations on applying this to Medicaid. But False Claims Act plaintiffs have brought suit nonetheless and have won. And so that's always Kayla and I's greatest concern working with women's health platforms, maybe depending on what portion of women's health from OB services, to older patients. A lot of our clients don't have large Medicare populations necessarily, but they still have to worry about it if they have large Medicaid populations. So that brings us to why we're talking about it. You're adding ancillaries. The reason you're adding ancillaries in most cases is alignment with your physicians, making sure patient care, profitability, costs all line up. And so because Stark applies, because the anti-kickback statute applies, ECRA at the federal level, and then applicable state laws, you have to be thoughtful about how you do compensation and how you do alignment. And we sort of broke it down here into two buckets. One, alignment and compensation through the group practice. You can do it as personal production. The physician's doing their own lab reads. They're doing their own image reads. You can pay them for that, for their professional service. You maybe can't pay them for the technician's work, but you can pay them for their own service. And lawyers will get to that kind of code by code basis in terms of helping you figure out how to split that revenue if you want to align that way. You can also pay with profit shares, and this takes the quote-unquote designated health services or the ancillary revenue pools it and pools it among at least 5 physicians. That's the CMS rule. You either have to share with the entire group or a subset of 5 or more physicians. If you're going to divide in a smaller manner, and allows you to share profit with them from these ancillary services to build alignment, to build the right care model. And you can do a lot of things here, and you can do a lot of changing of this over time. So you can kind of split that profit as long as it's not based on who made the referral, but you could split that profit based on production. Who your more profitable doctors can share in a higher piece. The doctors that are doing things like helping you build alternative payment models or doing kind of lead generation, you could increase their percentage from these pools. So there's a lot of things you can do. Just can't be based on referrals. It also needs to be set prospectively. You also, in most of the structures Kayla and I work with, and for those on the phone that are investor-backed, it would be the kind of also through the management company, there could be alignment through the MSO in their ownership. If you have physicians who own at your MSO, they can roll over as well, and you can have that kind of alignment. So as we think about this and talk about kind of building this out, I know this diagram ended up being a little bit busier than I intended it to, because I wanted to show in the simplest model how what we typically do, take lab, for instance, is if you can build a lab at a state-by-state basis or a practice-by-practice basis, you can really get some really strong alignment there with the physicians, with the services being done within their practice entity. And we typically see it as this, picture shows with state separation, different practices in each state, each practice with its own lab that the regs give us the most defensibility, and you can do some of that profit sharing I mentioned on the prior slide. But the problem with that, and we mentioned it already, is labs especially have expenses on them that they didn't always historically have. Some of that machinery for some of the genetic testing is running into the millions of dollars, and depending on your patient population and your size of your practice, as you grow state to state, you don't always have the scale in order to align things here and buy that type of equipment to service on a practice-by-practice basis or a state-by-state basis. So one of the things we've worked with some clients on is continuing that concept of a practice-by-practice basis. You have some of those protections to the Stark Law, to ACRA, to state laws that I mentioned before, but you don't have to do a practice per state necessarily, especially if you have some of that high-end equipment. Maybe you can have your Northeast practice, the women's group as we have it labeled here. It sort of started in the Northeast. Maybe you wanted to expand to Michigan and Georgia, and instead of starting a new practice, you took your Northeast practice over there. It can complicate things from a payer contracting perspective. You may have to have multiple different state Blue Cross plans, for instance, but there's some ways to kind of have one super PC or regional super PCs to allow them to grow and support some of that purchasing of equipment. Another option we've seen and worked through in these types of contexts, and this can be done either the entire lab or potentially the specialized lab equipment, is instead of seeking that alignment within a practice, maybe you can do it with your MSO entity, your management entity, or another investor-backed entity, is set up kind of an external lab. Maybe it doesn't do all the pathology, maybe it doesn't do all the testing, but it does some of the high-end stuff that you need national scope for, or you need other women's groups, not necessarily just those in your platform, but those maybe you'd work for to refer as well. And you can kind of set up a separate wholly owned lab. There are risks to doing this, and that's why we have the stop sign on the slide to say, hey, referrals from rollover physicians can really lead to more challenges. But maybe you can set up a lab for some of the highest end genetic testing where you don't let the rollover physicians refer, or you can actually get them out of the ownership, keep them out of getting the economics for it. But as a platform, you can still have access to some of that higher end testing and make the economics work while still allowing alignment maybe at a practice level for some of the more traditional lab testing that you may be doing or may be pursuing as you add. So with that, I'm sure some questions might be coming in the chat, but I will turn it back to Kayla. Again, wanted to make sure we had a chance to share some of what we're seeing as people navigate some of these ancillaries, particularly in the lab context. And again, would welcome chatting by email or LinkedIn to kind of continue these conversations. Kayla?
Yes, thanks, Tim. So Tim just discussed many of the ways that ancillaries can be brought into the business, but for you who have physicians that you're bringing in, or for you that do not yet have the capability to have those ancillaries in-house, what we are seeing is strong levels of questions from our clients about how do you navigate relationships with your physician partners when the ancillaries are outside of the practice, or when other relationships are outside of the practice. I suspect that this is something that almost everyone on the phone has grappled with at some point, and I know that Tim and I grapple with every single day from questions from clients and contacts. So with that, I thought it would be helpful to talk a little bit about the most common outside physician relationships, and then we can talk about how to tackle each one and what the risks and benefits can be of these different relationships. So first, let's start with investments in outside ancillary businesses. The most common investments that we see for women's health businesses are laboratories, imaging facilities, and either ASCs or birthing centers. And so I was just going to describe a little bit of the types of investment vehicles that we see for each of these structures. So for laboratories, it usually comes in one of two flavors if the physician is invested outside of the business. So number one is a direct investment in a non-governmental lab. So for all of the reasons that Tim discussed during the previous section, we often see direct investments in laboratories being framed as non-governmental providers and usually non-commercial providers in states that have strict self-referral and anti-kickback statutes. So it would not surprise me if one of your affiliated physicians has brought that type of structure to you as a practice and asked you to opine on it. The other structure that we often see people bringing and dealing with is investments in a management company that ultimately manages a laboratory in a particular market to which a physician refers. And practices that do not have this direct investment, but do have physicians that are invested, often have to look at those investments and analyze some of the risk and benefits that we'll talk about on the next slide. The next thing is on imaging. Very similar flavors as labs. We often see direct investments in diagnostic mammography, so mammography that is not considered a designated health service, or investment in a management company structure that is providing services to a mammography company. And sometimes we even see an investment in an equipment venture that ultimately leases equipment to different mammography ventures. So that may be another type of venture that you as a practice or you as someone diligencing a practice have seen come up that is of potential interest. The next is birthing centers and ASCs. So for practices that have a heavy amount of surgical volume, it's not uncommon to see the practice itself invested in the surgery center, but it's more common to see individual physicians invested in the surgery center. And so we'll talk about some of the ways to deal with that type of investment and to analyze it from a both economic and regulatory perspective. And then some of you may be located in a state where birthing centers are licensed and permitted facilities. And some states permit physician ownership in birthing centers depending on the state law and other requirements of exactly what codes are being billed. So you all may be seeing your physicians come to you with those type of questions as well. Then the next type of services we see that physicians have outside investments in are consulting relationships with usually pharmaceutical companies or medical device companies. We'll talk a little bit about the types of risks that come with these, just if they're not done properly from a governmental investigation perspective. And then they may also have clinical research relationships that either run through the practice or outside the practice. And then the next category is independent contractor relationships. These are typically centered around hospital relationships. And they're either medical directorships, call coverage arrangement, laborist services, and then sometimes you will see other part-time professional services with other medical practices that as an organization you'll need to deal with. And then the last is expert witnesses. It is very common to see outside physician relationships include expert witnesses, and sometimes that can have negative or positive reputational impact on a practice. So we'll talk a little bit about in the next slides how to deal with those items. So first and foremost, what are the regulatory considerations for these different outside physician relationships? I'm not going to recap these laws in detail since Tim has already talked us through them largely, but in nearly every relationship that I mentioned, so just going back here on our previous slide, any investments in outside ancillaries, any consulting relationships, any independent contractor relationships, they will almost always be a financial relationship between a physician or the practice and someone to which the physician or another physician in the practice refers. And what that practically means is we're going to have to grapple with the federal anti-kickback statute, the federal Stark law, and to the extent labs are involved, ECRA, which Tim mentioned a little bit ago. And so we'll talk about the process by which you can go through and analyze these different outside investments that have nothing to do with the practice directly, but can impact the practice. The next item is related to federal billing requirements. Anytime you have outside physician relationships and the services are being provided to practice patients or using practice resources, you need to be very aware of the potential billing requirements associated with that structure. It may be necessary to bill those through the practice, or it may be required to bill them outside the practice in order for them to be permissible. So it's just important that you have appropriate staff to be able to analyze any kind of billing requirements for the services. The next is FDA restrictions. There is a substantial amount of clinical research, more commonly in fertility, but we do see it a lot in women's health too. And if any clinical research is going on by physicians that utilize practice space, practice resources or practice patients, it's important to make sure that that clinical research is being done consistent with the FDA requirements and restrictions related to the clinical research. And that could be a whole separate webinar all on its own, but it's just a flag there. If you do see this happening in your business, it's important to ensure that those laws are being followed. And then the last item is state laws. And these are often forgotten, but can be very important because we have seen an upward trend in state enforcement of state anti-kickback, self-referral laws, state antitrust restrictions, state fee-splitting laws, all of those laws that impact how physicians practice, whether it's inside their practice or outside of their practice. So if you do have a particular outside activity that you think may not implicate federal law, just don't forget to check on the state law because the relationship very well may implement one of those laws because they are not in most situations identical. So as an example, for anyone who is operating in Maryland, Maryland has a very strict state self-referral law that is actually more significant than the federal law in many cases. So just be on the lookout for those deviations as you are looking at these outside activities, because to the extent that the outside activity is for the individual physician, it still could violate one of those state laws. And ultimately, if you have an individual physician in which you're employing that's violating a particular state or federal law, it's often going to loop in the practice. Even if you're not named in a particular investigation, it's going to take resources to respond related to billing, related to practices of the practice. So it's just best to get on top of those if you're able to. The next thing is business considerations related to outside physician relationships. This is the checklist that I typically recommend that clients go through when any physician relationship is brought to them for consideration or approval. So the first is, how much time is going to be required by the outside services? Is this something that's going to materially detract from what the physician is doing in the practice, or is it something that's actually going to bolster it and they're going to become better in the community as a result of the service? The next is the flow of economics from the outside activity. Is it a situation where the physician is going to be utilizing patient resources practice resources and patients of the practice, but the practice is not inuring to the economic benefit, and is the practice comfortable with that? The next is IP and work product generated during the outside activity. Many of these outside activities will have restrictions on how you can use work product or IP generated during the outside activity. So it's important that the practice understands that if the practice also expects to have a right to that IP or work product. The next is the single most important for anyone considering a future transaction, which is competitive restrictions and considerations. Many outside investments, particularly ones that are an equity investment versus a consulting relationship, will have an associated non-compete and non-solicit. And in the event that your particular practice is looking for a sale or you're diligencing a practice that's looking at sale, if there is a non-compete involved for an individual physician, even if it's not on the practice as a whole, that can be a major impediment to a sale process. So making sure you're aware of those and policing those to the extent possible is helpful.